Let's break down what I mean by picking a measure versus strategically choosing a measure. So MIPS, HEDIS, and UDS basically are all asking private practices to do the same thing. They want you to increase the quality of care that you give your patients and decrease the cost while you're doing it. These metrics are not isolated, they actually overlap, and focusing on just one area, in my opinion, will actually lead to missed opportunities. So, how do you choose measures that will actually improve quality overall? You do that through data. Let's say that you work for a primary care clinic and leadership agrees that value in primary care makes logical sense, because when you look at the list of it, let me see if I can blow this up. So let's see, ophthalmology, absolutely not. No derm, no gastro. We don't want to do any pulmonary, absolutely no surgery. What is that? Urgency medicine, nope. Cancer, nope. Heart disease, nope. Room, nope. Stroke, nope. Women's health, maybe women's health. Lower extremity joint, nope. Immediately no. Immediately no. 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 Ear, nose, and throat, no. So yeah, I mean, out of the options, it makes the most logical sense. So you don't really have a choice, because they're definitely going to bill $90,000. Probably going to have at least 200 patients, or will definitely hit the 200 servers throughout that 365 calendar year that will automatically qualify them. But let's say you are a very small clinic and you get that 3-point bonus. When you look at the requirements and none of the others fits, and you settle on primary care, this is the part where I am referring to where you are picking versus choosing. Let me show you exactly what I mean. So you have to pick 4 quality metrics from the list. One must be an outcome measure or either a high priority measure. And this is where the fun begins. There are 13 measures listed, but only 5 of them are not high priority, and they're all process measures. So you think I'll pick 3 process measures and 1 high priority measure. But let me walk you through why that's a bad idea, just again, to pick something, because it seems like it may be an easy and a nice go-to route. The first one is going to be process number 134, which is basically a preventive screening for depression and its follow-up. It is for everyone in your clinic age 12 and over. They must be screened for depression once in that calendar measured year. The follow-up plan, as documented here, must be done either at that appointment or within 2 days of it, if it is a yes for the screening. Process number 438, statin therapy for prevention. Process not high priority. It's basically the percentage of patients with high cardiovascular events who are adhering to their statin therapy. Sounds simple, right? This measure requires screening across 4 different population criteria. So your staff, your billing team needs to be aware of coding, patient selection, and medication adherence to all 4 populations to make sure that is correct. The next one, 475, it's not high priority, it is a process measure. It is HIV screening. Everybody age 15 to 65 need to be screened. I'm not really sure if I agree with the 65, because I have worked in nursing homes, and that I'm not sure if I agree with that. So now, as a leader, you have to ask yourself, do you have the ability today to see how many are missing? And if you can tell out of your entire population how many are missing, do you know which ones are associated with your TIN that you will be penalized for? Okay, so now we're moving on to 493. It is not a high priority, it is a process. 19 older who is up to date on routine vaccines. This also includes flu. And again, you have 4 performance rates to submit. If they get the flu shot somewhere else, do you have follow-up protocols that can let you know in real time to make sure it is in the chart for every last one of them? Or do you have to wait in hindsight to get this data to find out that you missed some? Then moving on to the final one, preventive care and wellness. Seems simple. This one includes 7 separate measures all under one, and they're not related because this is where they put your BMI. CMS is basically creating MVPs, and they're going to create all of them until all 198, 95, 200, however many measures there are, until all of them, especially the high priority, the patient reported outcome, and the intermediate outcomes, until they're all in their own individual MVP. So get ready, because in 2025, this is just what you're being graded on now. Now, let me ask you, does your office currently have the systems, workflows, and processes in place to effectively manage these tasks? Which of these do you feel the most confident about? Is your billing properly set up? Does your staff know exactly what to check to ensure proper screening? How would you track follow-ups in real time? Are your workflows, staff capacity, and technology ready to meet the demands? Because remember, if you do not screen 75% of the eligible members, you get a 0 for the entire measure. Your data has to be complete. Incomplete data is automatically a 0 unless you are a small clinic, and then you get those baseline 3 points. But you also have to remember that if you are a small clinic and you only get those baseline 3 points and you end up basically getting a 0 in quality, it's worth more than 30%. I think it's like 40% of your score, because you get a pass on promoting interoperability, and the scores spreads across the quality, the improvement activities, and the cost, so your quality would actually be higher. All of this, and you haven't even picked your patient population, which includes readmissions and ER visits, and your high priority measures, which focus on areas like appropriate use, patient safety, efficiency, patient experience, care coordination, health equity, or opioid related care. Some of the most impactful areas. Well, let's say you are a primary care clinic and you know without a shadow of a doubt you have a high population of non-compliant patients that don't follow up. They barely take their meds and use the ER like it's urgent care. Ask yourself, do we have workflows and staff capacity to track, act on, and document these follow-ups? Can we monitor these in real times, or will we find out we failed when it's too late? Is everyone trained? Is this embedded in our daily workflows, or will it fall apart the moment we get busy? This MVP requires structured data. Are we accurately documenting in structured fields? Is our EHR even certified for this? Are we picking MVPs because it's for primary care, or because it aligns with what we can actually deliver? You have to know if your technology, the systems, current workflows you have in place would meet the demands required. Because remember, when you're reporting, you're grading your implementation. They're expecting you to be in the testing and scaling phase, but most clinics are probably just getting started. MIPS is loaded with expectations around care coordination, follow-up, chronic disease management, and social needs screening. Before locking in any MVP or any measure at all, pause. Audit what your team can constantly deliver. Map what's real. Look at your workflows, your staff capacity, your data, your patients, then choose strategically, not based on convenience. Because this isn't about checking boxes. It's about knowing what your practice can back up when it's time to report. Here's what I want to know. What's one measure you've seen that sounds easy, but know your team would struggle to track or follow through on?